adrenal gland. Corticosteroids, this is the hormone that is our discussion today. As you know already that adrenal gland, it is above the kidney, and there are three parts of it. One is capsule, the other one is cortex, and the third one is medulla. Our today's discussion that is about the corticosteroids, that is related with cortex. Cortico is from the cortex. And then again, you know that there are three different zones, as you discussed in histology, in cortex. One is called zona glomerulosa, the second one is called zona fasciculata, and the third one is called zona reticularis, or what we say GFR. G for glomerulus, F for fasciculata, and R for reticularis. So these are the three zones where these hormones, different type of hormones, they are released. The first one in the zona glomerulosa, the hormone that is released that are called mineralocorticoids. The second one, that is the largest portion or zone, that is the zona fasciculata. It releases the hormones that are called glucocorticoids. And the last one in this, that is in the zona reticularis, they are called androgens. As regards catecholamine, you already discussed with Dr. Fathi, and maybe in physiology, that is from the medulla region, although in one way the function of both is same, that they help us in stress. These hormones, they are very helpful to manage us in stress. You remember autonomic physiology, when there is fight, flight phenomena or fear, then our body start to release adrenaline. So adrenaline is one of the catecholamine, apart from noradrenaline and dopamine. Before that, in zona reticularis, that is the androgens. The first two we will discuss, mineralocorticoids, and the second one, that are the glucocorticoids. Androgens, that are the sex hormones. These are the sex hormones. But try to understand that these sex hormones, which are released from the adrenal gland, adrenal gland, and androgens are the male sex hormones. So male sex hormone is testosterone. Male sex hormone is testosterone or testosterone. But keep in mind that this is not the only place where the testosterone is synthesized and released. In males, mostly it is synthesized and released in the testes. It is from the testes, but still the adrenal gland releases certain androgens. They are more important for females. As you know that females have also male sex hormone, testosterone, although the female sex hormones are more, estrogen, progesterone, oxytocin, they are more, but still certain amount of the androgens, they are released from the adrenal gland, from the zona reticularis, and you know the female secondary sexual characteristic, like growing hair in the armpit, axilla, also in the groin area, also these that is under the influence of the androgens. In females, I am repeating again, in females. In males, that is under the influence of testosterone from the testes. So that is the androgens that are the part of the cortical region of the adrenal gland. Okay, first one, mineralocorticoids. Mineralocorticoids, look, it is a combination of three words. Mineral, so we know already minerals mean sodium, potassium, calcium, blah, blah, blah. All of them, minerals are electrolytes. Cortico, because it is related with cortex. And the third one, oids, because they are steroids. So, as you discussed with Dr. Fathi, the source or the precursor is sterol, and sterol is a cholesterol. Sterol is a cholesterol. So, we say mineralocorticoid or glucocorticoid. Why? Because three things are involved in this: minerals, the cortex, and the chemical structure. Okay, so we say mineralocorticoids. As you already know, there are three important body organs. They play important role: hypothalamus, pituitary, or what is it? Pituitary, pituitary or pituitary is easy, I think. Anterior pituitary, that is responsible, and then it sends a message to the adrenal gland. Okay, so this is called axis. Axis means that three different organs are involved and they connect with each other. As we will discuss even in today's case, to us adrenal gland is important because the first two, they are more related with CNS like thing. They are endocrine, but hypothalamus is part of the CNS, although the process starts from there. Okay, coming back, mineralocorticoids are involved in the regulation of electrolyte and water balance. We discussed many times in renal module, sodium goes, water goes. Sodium retains, water retains. So, these mineralocorticoids, they help in the water balance. How they help in the water balance? Because they increase the reabsorption of sodium. So we know that sodium retains, water retains. Potassium is going, but when sodium is retained in the body from the nephron, it is going back into the body, water will also go back. So that is the regulation of the water balance. Now, we have two types of mineralocorticoids. One is the natural, or what we say endogenous, and the second one is the synthetic. If you remember, we discussed in CVS, cardiovascular system, RAS, renin, angiotensin, aldosterone system. Renin, angiotensin, aldosterone system. It is a regulatory system wherever the body needs to increase the blood pressure. To increase the blood pressure naturally, like our blood pressure goes down, so these hormones, they try to increase or to bring it to the normal. So one of the hormone that plays important role, that is aldosterone. Why it is important? Because it helps to retain water and sodium. And whenever there is retention of water and sodium, it will help to increase the blood pressure. Okay, so aldosterone is an endogenous mineralocorticoid. Fludrocortisone, you can just fludro from fluid, because they help to retain the fluid. Fluid is water and sodium. So the synthetic one is fludrocortisone. It is used where the body needs. Where does it need? We will look at here and also later on in our today's PPL case. Uses in the treatment of primary Addison's disease. Primary Addison's disease. You discussed in physiology, pathology, or Amafi. There are three types of Addison's disease. What is Addison's? Addison's is the name of the scientist who discovered this disease. Thomas Addison, who discovered it in 1980 or something, 1880, not 1980. The disease where the body is insufficient on the hormone. What is the hormone? Cortisol. Cortisol is the corticosteroid. The body naturally producing everyday cortisol. If we don't produce cortisol, we will die from the stress. The BMS stress, the radiology stress, the Arabic language test stress, all the stress that we get and we manage, that is due to the cortisol. The body produces cortisol. Cortisol always help us to manage these stress. So that they are important in this. Now there are three types of Addison's disease and it goes in reverse order. And technically the primary is called Addison's. What is primary? When the reason that the body is unable to synthesize and release cortisol due to adrenal gland. And you discussed with Dr. Ali, this area is very important for the cancer. Kidneys, the adrenal area for metastasis. Metastasis is part of cancer. So, for any reason, if the body is unable to produce sufficient amount of cortisol, so what we will say, this is primary Addison's disease. This is primary Addison's disease. If the reason is pituitary, anterior pituitary gland, then we will say this is secondary. If the reason is hypothalamus, although starts from hypothalamus, but here we go in reverse order. If the reason is hypothalamus, then we will say tertiary, but ideally we say tertiary adrenal insufficiency, secondary adrenal insufficiency. But when we come to primary, then it is Addison's disease. Okay? So we use it if the body is unable to produce sufficient cortisol, and cortisol as well as mineralocorticoid aldosterone. Because in primary, both problem, cortisol as well as mineralocorticoid. In secondary, maybe only cortisol, RACTH, we will see that. This is first one. Second one, there is another problem that is called adrenogenital. Adrenogenital. Genital means organs. Which organs? Genitalia are reproductive organs. So, adrenogenital, this is mostly females' problem. You might have seen, Nair, you might have seen females with male characteristic. What is it called in Arabic? Females, but male characteristic. Transgender in English, I don't know what is in Arabic. If you Google it, transgender.
We don't have a specialty.
No, how is it possible? Arabic is, mashallah, a language.
But it's not polite to say.
Okay. But you understand it?
Yes.
Yeah. Okay, good. So, what happens? Adrenogenital, because for females, the most important organ that she looks like female is breast. Here it is opposite. There are no breasts, or very small breasts. But rest of the body, it looks like male, adrenogenital. Uterus is small. Uterus is small. The legs or the thigh region, they are strong, muscular, like males. Females, these organs, they are not muscular. Males are muscular. So in that case, again we can use it. So there are two conditions where we use mineralocorticoid. mostly, and if it is discovered in children, because when she grown up, then it is difficult to treat. But when the child is very young and we come to know that there is some problem, this is mostly chromosomal problem. So then what we do, we give this drug. First one, that is in adrenal insufficiency, primary, that is Addison's disease. Second one, adrenogenital syndrome. Now we go to the side effects. Hypernatremia. As we discussed, because mineralocorticoid increase the reabsorption of sodium. Increase the reabsorption. So what will happen? It will lead to hypernatremia. Second, it will cause hypokalemia. What is going on? Potassium loss. So there will be hyponatremia. And the third one, when there is hypernatremia, what will happen? There will be hypertension. Okay? So these are the three side effects. Now we go to the synthetic glucocorticoids. Again, what you will use in your clinics most commonly, that those especially who are going for oral medicine. Almost always oral medicine, they start with glucocorticoids. Any problem in the mouth is immune mediated initially. Later on, God forbid, cancer, whatever. But initially it starts with immune mediated. So we try always with glucocorticoids. Maybe oral gel, maybe tablets, maybe injection. Everything first we start with glucocorticoids. Why? Because we discussed many times the most potent anti-inflammatory drug. Glucocorticoids, they are the most potent anti-inflammatory drug. Now here, many times you will see the term steroids. The term steroids. Even when you will discuss with your friends, 5th year, 6th year, and later on in clinical life, and you will say, and the patient will tell you, the doctor gave me steroids. You know steroids. Many times this is you. Try to understand the difference. Steroids are of two types. One are called anabolic steroids, and the other one are called catabolic steroids. So these are catabolic steroids. They are useful. We need them to use for different type of problems. Anabolic steroids are the testosterone. They are illegal street drugs, including Saudi Arabia. You cannot find these drugs. Why? Because they are used by athletes, they are used by sports people, or sometimes we say these are street drugs. Why? Because they increase the performance. So that are the anabolic steroids. In clinical practice, the term steroid means glucocorticoids. Glucocorticoids. Hardly you will see any patient is using fludrocortisone. Why? Because fludrocortisone is only specifically used for primary Addison's disease or adrenogenital. How many people suffer from this? Very rare. Hope inshallah you will never see any patient with this. Very rare problems. But glucocorticoids, I used to joke, oral medicine people write like candies. Any patient comes to the clinic, first they try with glucocorticoids. Again, it is 3-word combination. Gluco is from glucose. Gluco is from glucose. And glucose is carbohydrate. Glucose is carbohydrate. Cortico, already we discussed that it is cortex. Oids, steroids. Arcoids, steroids. Okay? So, because they play important role in the regulation of carbohydrates. Primarily, they play important role in the regulation of carbohydrates. And you know from your biochemistry that carbohydrate, protein and lipids, they are interlinked. When our body does not need glucose, what will happen to the glucose? It will go and it will store as glycogen. You remember glycogen? Yeah. And similarly, gluconeogenesis. When we don't need glucose, it will convert into lipids, into proteins. Whenever we need, then we will utilize. Okay, so these steroids or glucocorticoids or cortisol, they interfere with the synthesis of carbohydrates. Okay, now we will see how is it important for us before first we look at the classification. Classification based on potency and duration of action. Potency and duration of action. Now, keep in mind, you will see them to be used by different route of administration: oral, injectable, intramuscular, intravenous, subcutaneous, intraarticular, any route you can mention and they are available. Then we have inhaled, as we discussed in respiratory renal, inhaled corticosteroid, fluticasone, budesonide, they are inhaled corticosteroids. Topical application, we use steroids locally, dermatology, jildia. Any patient goes there, they prescribe clobetasol or beclomethasone or dexamethasone, or so many of them are there. What is important? We classify them based on potency. Potency means the dose. And the second one is duration. How long acting is the drug? So that is the two reasons. First one, prednisone converted by the liver into prednisolone. So what is prednisone? Prednisone is pro-drug. Prednisone is pro-drug. The body needs to activate it. Where it is activated? In the liver. So remember, if the patient is suffering from liver disease, we will not use prednisone. Why? Because the liver is not working. The liver cannot convert it into active metabolite prednisolone. So what we will use? We will directly use prednisolone. The second one is prednisolone. Third one is methylprednisolone. All the three, they are same, except that methylprednisolone is also used as injectables. Injection. Methylprednisolone is injection as well as tablet. Now, next is hydrocortisone. Hydrocortisone is acting almost same like natural cortisone. What I told, that our body daily produces certain amount of cortisol, and that is the reason that we manage the stress. Hope you discussed with Dr. Ayman. The body produces maximum cortisol when we get up in the morning, after 1 hour, something like that, 7 to 8 a.m. That is the best time, and that is the time that you come for exam. So 7 to 8 a.m. For this reason we tell you, come early morning for exam. You say no, exam should be 12 to 1. Okay. So when you awake in the morning and after 1 hour or so, the maximum amount, this is called circadian or impulsation. It changes with time. So morning maximum, then goes, when we reach again AM, 3 AM. So you can say 8 AM maximum, 3 AM. 3 AM means very late at night, like you send me messages very late at night, where there will be exam or mafi, there will be class or mafi. Yeah, doctor, who is there at 3 AM?
That is the emergency.
Yeah, so 3 AM minimum cortisol. Minimum cortisol. That is natural, what we are talking about. Natural cortisol. Now, hydrocortisone is almost same like natural cortisol. Okay? Then we have dexamethasone. If you look, dexamethasone is highlighted in red and written in black. This is potent as well as longest acting. Two things are there. Small dose and duration is very long. Even single dose is sufficient for 3 days. How many days? 3 days, 72 hours. So this is potent as well as longest acting. If you get question on your exam, which of the following is potent and longest acting dexamethasone? Okay, you will find also more potent, but they are not so long acting. They are long acting but not longest acting. 2 days, 3 days, no. Mostly you need to repeat the dose. Okay, then we have beclomethasone, budesonide, fluticasone, betamethasone, triamcinolone, and clobetasol. We should stop here on the betamethasone. From beclomethasone till betamethasone, mostly they are inhaled. They are inhaled. We already discussed in respiratory, there are inhaled corticosteroids, ICS, inhaled corticosteroids. So they are inhaled corticosteroids. Then we have triamcinolone. Triamcinolone is tablet as well as injection as well as topical. Marham you say, huh? Cream, gel, these are available for triamcinolone. Then we go to clobetasol, mometasone, they are both topical as well as oral. And the last one, that is loteprednol. Loteprednol is I, ophthalmic preparation. Ophthalmic preparation. So what I told you, name and you will find these, they are used for different purposes. They are used for different purposes. Injectables, intramuscular, intravenous, subcutaneous, intraarticular, oral, tablet, syrup, both are available. Then creams are available, then eye drops are available, ear drops are available. So they are very useful. Why they are very useful? Because they are potent anti-inflammatory drugs. They are potent anti-inflammatory drugs. Now we come to the mechanism of action. Interesting mechanism of action. Glucocorticoids, they work by modulating gene expression. So where are the genes in the body? In the nucleus of the cell. In the nucleus of the cell. So we have two types of mechanism of action for glucocorticoids. One is called genomic, that it will make a complex in the cytosol or with the cytoplasm. It will enter into the nucleus of the cell. It will work with messenger RNA and make new proteins. And the other one is non-genomic. It will work or it will inhibit certain proteins that increase the apoptosis of inflammatory cells. We will come to this. First look to the next slide. I think you also might have discussed with Dr. Fathi. Steroid hormones. The mechanism of action of the natural and synthetic is same. What will happen to the steroid hormone? This is the cytoplasm, you already know from the cell. And this is the steroid receptor, and this is a hormone receptor complex, and it will enter into the nucleus. Now it will enter into the nucleus, combines the receptor on the chromatin activating messenger RNA transcription. Messenger RNA transcription means that it will produce new proteins. And these new proteins, they are anti-inflammatory proteins. They are anti-inflammatory proteins, and they are called lipoproteins. They are called lipoproteins. Now look here, we discussed all these things. This genomic inside the cell, lipoprotein. What is the role of lipoprotein? It will do two things. First one, inhibition of phospholipase A2. Phospholipase A2. And second one, inhibition of COX-2. If you remember, we discussed COX-2 already in analgesics, non-steroidal anti-inflammatory drugs, COX-1 and COX-2. If it is COX-2, then we say selective. Here, what it will do, that it will act on two pathways as you discussed in biochemistry. In the phospholipid is converted into arachidonic acid. Phospholipid, when it is converted into arachidonic acid, the enzyme is responsible, that is called phospholipase A2. Then the next step is the arachidonic acid is converted into prostaglandins. For prostaglandins, COX-2 is required. So it will act both on first step and second step of the prostaglandin synthesis. This is called genomic mechanism of action. It is inside the nucleus. Now non-genomic, that will be in the cytosol or in the cytoplasm. What it will do, that it will act on the proteins HSP90, HSP70 and P23. These are the proteins that are important in the apoptosis of inflammatory cells. HSP means heat shock proteins. Heat shock proteins. Heat shock protein 70, heat shock protein 90. What is the benefit when we cause the apoptosis of the cell? Cell will die or it will grow more? It will die. So which cells? Inflammatory cells. So the inflammation will increase or decrease? Decrease. So by two mechanisms, for this reason they are called the most potent anti-inflammatory. By three mechanisms, it reduces inflammation. By phospholipase A2, by COX-2, and by non-genomic, the proteins which help in the apoptosis of inflammatory cells. Okay, so that is the mechanism of action of glucocorticoids. Now we come to the uses. Three categories of glucocorticoids. As we discussed, that we can use it by any route of administration. First one is systemic. Systemic means when we use it oral, injectable, in oral tablet, capsule, syrup, then this is systemic. Where we use, what are those we use as systemic? Prednisolone, hydrocortisone, and dexamethasone. Prednisolone, keep in mind, prednisolone and prednisolone. If it is prednisone, then we cannot use it in liver disease. But if it is prednisolone, because prednisolone is active metabolite or active molecule, so we can use it even in liver disease. Okay, so allergic and inflammatory disorders. Allergic, any allergy that we can suffer, we can use them. We can use for any allergy, allergic dermatitis, atopic dermatitis, urticaria, any allergy condition we can use. Why? Because in allergy there is vasodilation due to histamine release and prostaglandin, and they act as vasoconstrictor as well as it blocks the prostaglandins. Okay, similarly we can use it in inflammatory disorders. Inflammatory disorders, we know that these are autoimmune diseases. Do you know any inflammatory disorder that is autoimmune? And you discussed, and we discussed, and you know what is that? rheumatoid
Arthritis.
arthritis. Rheumatoid arthritis is autoimmune disorder, and if you remember in musculoskeletal we discussed quite in detail that we can use, and we use these glucocorticoids. And even I told that we had a patient before Ramadan and she was using glucocorticoids for the last 2 years. Normally we don't use it for so long. We will see in the side effects what is the duration for which we can use. But sometimes you will see the patient use it for longer duration. Longer duration, only we use it for the Addison's disease. Lifetime only in Addison's disease. Because there it is the replacement therapy. Okay, used as part of a wider chemotherapy regimen. Wider chemotherapy. Chemotherapy is used for cancer, very good. Now in cancer there are two problems. One is immunity. The immune mediated, the cells multiply very quickly, so because it act on the immune cells to suppress. Second problem, if you know anyone, God forbid, who is suffering or who was suffering from cancer, the most difficult thing for the cancer patient, two things: pain, and second one, vomiting. Vomiting is too much. Why? Because all the chemotherapeutics, the drugs that treat cancer, they cause severe vomiting. Severe vomiting. And they help to reduce the vomiting. So we used it in this chemotherapy regimen. Third one, as I told, hormone replacement condition such as adrenal insufficiency. In bracket you can write Addison's disease. Okay, then we come to next, that is inhaled. Inhaled, as we discussed previously in respiratory tract, we have fluticasone, we have budesonide, we have betamethasone or beclomethasone. They are used by inhalation. Bakhar. In the treatment of asthma and chronic obstructive pulmonary disease, or COPD. Okay. Then topical cream, lotions, gels, ointments, whatever we can use locally that are topical. Hydrocortisone, betamethasone, triamcinolone, and mometasone. Treating inflammatory skin conditions, what I told, atopic dermatitis. Atopic dermatitis is eczema. And then oral diseases. Oral diseases is what I told, oral medicine. Aphthous ulcer. I don't know you started dentistry or not yet. Aphthous ulcer, very common problem, ulcer in the mouth. Eczema, atopic dermatitis. Yeah. Eczema is broader term. Then we have atopic dermatitis, inflammatory dermatitis, urticaria, then idiopathic, all of them they are eczema. So we use the term eczema, or you can say skin allergy to make it simple. The other one, anything, any problem in the mouth, any ulcer, any inflammatory condition, we start, or we can use both oral as well as what I told, we use the gels, creams, oral. That will only we adhesives we apply in the mouth. There are lozenges. Lozenges, you know, like strepsils. Strepsils normally like candies. We put and we suck on it. So there are lozenges of these steroids. We gave it to the patients. Take it once or twice a day to reduce the inflammatory conditions. So that are the treating inflammatory skin conditions, eczema, and so oral diseases. Now we come to the side effects of GCS. Side effects with glucocorticoids vary depending upon the route of administration is required. Here, this is very important thing. First thing, as we discussed, that they are potent anti-inflammatory drugs. But the problem that we cannot use them for very longer duration. Maximum duration before COVID or Corona was only 2 weeks. How much? 2 weeks. 14, huh? 14 days. After Corona, after COVID, what we say post-COVID, they add 1 more week. Now we say maximum we can use glucocorticoids, talata asabi, 21 days. That is cut-off value. We will not exceed 21 days. If we exceed 21 days, get ready for the side effects. Get ready for the side effects. So if someone is using for longer duration, what we will do, we will gradually reduce the dose. We will gradually reduce the dose. If we stop all of a sudden, there will be crisis. There will be crisis. Why? Because you already send the message to hypothalamus and pituitary, we don't need steroids. They stop the factory. You know, Sanaya. The factory in the brain, after 21 days, khalas, it will go into dormant stage. It will not work. Mafi umal, everyone is gone. So, what we will do, we will gradually reduce the dose. Why? We will ask the hypothalamus, ask the umal, Bengali, Pakistani, Indian, come on, we will start again. If you stop all of a sudden, there is no one to work, then there will be crisis. And the patient will be in the hospital. So that you should keep in mind. First thing, we say that the side effects are related with route of administration. Agreed. Mostly it is like this. But unfortunately, these conditions sometimes, from time to time, they need systemic drugs. Like asthma patient. You know, mashallah, everything is now on the social media. Things are getting changed. For the last 2 months, there was wedding in India, Ambani family. You know about this? Ambani is very rich person. He is one of the richest person in the world. If you Google Ambani wedding, you will find many things. Girl students know about this. You just check Ambani family. You know, yeah, he is very rich person, and he asked so many people from the world to attend the wedding of his son. His son is suffering from Cushing syndrome. His son is suffering from Cushing syndrome. Why? Because he is asthmatic and he is using inhaled corticosteroids for the last 15 years. Although it is inhaled, but still, when we use these drugs for so longer duration, it can cause these side effects. And what I told, sometimes the inhaled corticosteroids don't work and you need to give oral. So that is making a problem. The point that we are making, that these side effects, they cause more serious systemic whereas inhaled topical routes less serious and local side effects. But still there is chance when we use it for longer duration, in larger doses, even the inhaled can do problems. Cushing syndrome. Cushing syndrome. So first thing, that it is opposite to the Addison's disease. Why? Because in Addison, there is insufficiency of cortisol. Here in Cushing syndrome, there is excessive cortisol. There is excessive cortisol. So that is called hypercortisolism, because the body is unable to manage excessive amount of cortisol. So it is in the blood. Okay. Now what will happen? We start from the face. In the face, first thing, moon face. Moon face mean round face. Round face. Why round face? All the fat that will come and that will accumulate in the central region. Face is the central region. So the face will be round, moon face. That is called the first side effect of the Cushing syndrome. Second one, there will be acne. There will be acne, pimples on the forehead or on the face or on the cheeks. Mostly when we reach 13, 14 years, then acne appear and then disappears. More problem cosmetically for females. Then we go to red cheeks, tomato-like cheeks. These are called metabolic problems. There is vasoconstriction. As we discussed that it causes vasoconstriction. So the face looks very red. You know tomatoes here. Baladi wala from other places. Both are red. Isn't it? Then we go to increased facial hair. Again problem for female. Hirsutism. Excessive growth of hair on the face. So that is related with sex hormones. Because the hair growth is directly related with sex hormones or androgens. Okay, then we go to next, thinning of hair. The hair will get thin. Why? Because the synthesis of the hair follicles, that is interfered. So it will be thin hair. Then we go to next, buffalo hump. Buffalo, you know buffalo? It is cow-like animal. Saudis don't like, and it is not here in Saudi Arabia because the weather is very, very hot. It is, if you go to India, Sri Lanka, these countries, Bangladesh, you will find this animal there. Even in Pakistan, but you don't come too much to Pakistan due to Afghanistan, maybe. Huh? Okay, so buffalo hump. If you Google, you will find buffalo. So buffalo hump, the back side is raised. That is called buffalo hump. Then we have extra fat around the neck. Neck is also big because again these are the central regions. These are the central regions. So the fat accumulate in these regions. Then we go to next, easy bruising, the skin, because again due to the synthesis of collagen, the skin surface, it is thin. So these patients get easy bruising. Then next is thin skin. Thin skin and easy bruising, they are interconnected. Next we come to belly. You will discuss it again with Dr. Fatih, inshallah, in 5th year in nutrition. Pendulous belly. Pendulous or apple-shaped belly. Pendulous from physics in your school. Pendulum goes like this. You know pendulum. Pendulous belly. The belly is big and it is apple-shaped belly. Again, belly is central region. So all the fat from the body comes and it accumulates in the central region. Belly, in the shoulder, hump and face. Okay, so that is the next region. Then we go to weight gain. Weight gain is for 2 reasons. One, because they take a lot of food. I'll make 3-4 packs maafi mushkil. Why? Because hypothalamus is activated. Hypothalamus, hunger station, not the hunger station that you order. We have also appetite center, that is hunger station. That tells you eat more, like in diabetes. Initially, diabetes patients, you know, they eat more. So that is first reason that there is weight gain. Second reason, as we discussed, that they help to retain sodium and water. So retention of sodium and water also give us more weight. Next is red stretch marks. Red stretch marks, especially in females. The skin of the abdomen stretched, so there are red stretch marks. These red stretch marks also appear on the female abdomen during pregnancy. So inshallah, when you will get married, you will know this. Okay, but just keep in mind. Then thin arms and legs weak bones. Thin arms. What happens, as we discussed, that everything is going central, and gluconeogenesis and fat redistribution. So the protein that is part of the muscles that is going wasting. So wasting of the proteins, that is cause thinning of the arms, that is called. And the second thing, as we discussed in bisphosphonates, in musculoskeletal, in osteoporosis, that it interferes with the calcium absorption and metabolism. So the bones become weak. So it can even cause osteoporosis. And then we go to next, slow wound healing. Why? Because there is excessive sugar or glucose in the blood. And bacteria likes sugar like us, like you order every day from a Dunkin' Donut and this and that. Why? Because all of us like sugar. The bacteria also like sugar, so they stay in the blood for longer duration, so that can interfere with the wound healing process. Why it is important? Inshallah, you will discuss with Dr. Fatih in diabetes mellitus. Every patient that comes to us downstairs in the clinic, first thing we do, finger prick for the diabetes mellitus. Why? Because if the patient is suffering from diabetes, wa alaikum salam ya doctor. So we should be careful. Why? Because wound healing is slow. Wound healing is slow. And you might have seen people, because unfortunately diabetes is everywhere. Diabetic patients, they wear special shoes. They wear special shoes. Why they wear special shoes? Because any injury then takes more time, longer time. Understand? So that is important, because there is excessive amount of sugar. The reason, one, that bacteria, second, insulin resistance. The body cannot utilize glucose. Inshallah, we will discuss, and you will discuss also with Dr. Fatih, what is the role of insulin. Insulin is key. It is key. So if we don't have key for this room, although the room is so big, but we cannot enter. So insulin opens, and then the sugar or glucose, that is the source of energy, then it enters into the cell. Insula. Insula means into the cell. It allows it into the cells. So there is insulin. Swelling of feet and legs. Why feet and legs? Because of the sodium retention. Because of the sodium retention. So this is all about our today's discussion for glucocorticoids and mineralocorticoids. Mineralocorticoids, they are aldosterone synthetic, natural, fludrocortisone synthetic. In glucocorticoids, cortisol, cortisone, they are natural, and then we have a very long list of the synthetic glucocorticoids. We have systemic, we have inhaled, we have topical. The side effects are more when we use them systemic, oral, injectable for longer duration. The maximum duration is talata asabi or 21 days. If we exceed, then get ready for the side effects. Remember, we will always stop the drug gradually. Otherwise, the patient will go into crisis. Okay? That is the story of our today's lecture. Finish, go home and enjoy. Rather, we have PVL.